Okay, here we go. Good morning, everybody. Thank you so much for joining us today. And today we have a really, really special session. We are interviewing Carol Ann here, who is an absolute specialist in the field of lipedema, lymphedema, and she is going to explain it all to you because it is very, very complex. And I can't wait for her to demystify everything. So, Carol Ann, would you like to briefly just introduce yourself?
Well, I've been working as a complementary therapist for 30 years, and 25 of those years as a lymphedema practitioner. And I do have a disclosure because I have lipedema and I was diagnosed 25 years ago. So I'm passionate about the subject, and it's a very neglected area of women's health. So thank you for giving me this opportunity to talk to you all
No,
about it.
we are absolutely thrilled to hear more. So I know you are like bursting with so much information to share with everyone. So what I'm going to do is I'm going to spotlight you, let you go,
Okay.
and just a note to everybody, as and when questions come up, please put them in the chat and we'll have some time at the end to answer questions. It might be just the heads up, it might be that we need a second session because there is so much to unpick and uncover here. So, Carol Ann, over to you. Thank you so much.
No, thanks for this opportunity. So, lipedema, what is it? Well, what it isn't is you're not fat, okay? So, a lot of ladies have been gaslit far too long, and the medical profession aren't really up and running with this. So, what is lipedema? Well, it was first described in the 1940s by doctors Edgar Allen and Edgar Hines as a chronic and progressive disease, predominantly affecting biological females, rarely affects men. And in 25 years, I've only ever come across one man with it, and he had hormone dysregulation. So it's an abnormal distribution of subcutaneous adipose tissue that we call SAT, or you will think of it as fat. Okay. It's not like normal adipose tissue at all. It's often accompanied by a lot of pain and sensitivity to touch and pressure in the affected areas. Because it's an abnormal distribution of this fat, ladies are often pear-shaped, and we'll go into the types and stages in a little bit. Certain companies and the Welsh Health Board have now reclassified lipedema as lipalgia, because in lipedema there isn't per se any edema at an early stage, but there is pain. So algia being pain, lipalgia probably is more descriptive of it, but that's not a defined categorization as yet. So it's symmetrical and it's bilateral. The symmetry can change as the disease progresses, so there can become more asymmetry. It spares hands and feet in the early stages, so you'll have a typical cuff sign that will come down, certainly in stage 3, when the disease is down to the ankles. Ladies, the legs are often columnal, so no particular shape, with hoodie knees and easy bruising. And one of the things in diagnosing the condition, we'll often ask ladies, in your teenage years, were you ever able to get knee-high boots? And most of them will say no, because of the thick set calves. So there are 5 types. Type 1 is pelvis, hips and buttocks, so what you'd probably think of as saddlebags. Type 2, it then progresses from that to the knees, and often there'll be, certainly in the medial aspect of the knees, they'll be quite sort of hoodie and start to maybe get a little bit more solid. Type 3, it then progresses down to the ankles, but we're still looking at sparing the feet. Type 4 is the arms, and again, typically will come into a cuff, and if it progresses to the lower arm, the cuff will spare the hands. Type Five is lower legs. And again, in 25 years, I've only ever had one patient with type 5. But quite commonly, we get combinations. So type 2 and type 4 and type 3 and type 4 are quite common. Although most ladies will have this columnar leg shape, some ladies, their legs have more bulges and they're more lobar in shape. There are three stages to lipedema. Some will say there are four stages, but I'll come into that. The first stage is typically the skin is quite smooth in texture, but there is still this pebbly feel when you palpate to the subcutaneous tissues, and the start of what most ladies would consider cellulite. Stage two, we start to get an increase in overall skin dimpling, and we're more likely to be clearer and see more fibrotic changes in the tissues. And there'll be a general increase in the size of the tissues at this stage. And sometimes, again, the nodules will be a little bit bigger. Stage three, we're now looking at a much more pronounced increase in the tissue size and in fibrosis, with much larger fatty nodules and an increase in maybe overhang of tissues. And at this time, there is very definitely more of a shape distortion, and often mobility issues occur. Then we have the progression to a lipolymphedema, which currently is referred to as stage 4, and that's where the lymphatics become involved, and that's a much harder situation. Then we like to be able to diagnose ladies at a much earlier stage so we can prevent these complications and progression. There's also another condition, but that's very rare, called Durkheim's disease, and I don't think we need to go into that today. Frequently with lipedema, there are a lot of other coexisting comorbidities that we see with ladies. They're much more likely to have underactive thyroid disease, and sometimes, although they're symptomatic, they might still form within the normal range for thyroid. So we need to look more closely at that, because they can go under the radar with hypothyroidism. Often also ladies will have hypermobility issues, and hypermobile Ehlers-Danlos syndrome is also something that we see quite often. A lot of depression, because on average, Lipedema UK study showed on average it takes 20 years for ladies to get this diagnosis. So it is pretty miserable. There are often occurs a lot of eating disorders, because lipedema fat does not respond to calorie restriction or exercise. So that can lead to eating disorders and yo-yo dieting. And because this fat is very quick to grow, it hypertrophies quickly, but it doesn't, like normal adipose tissue with calorie restriction that will shrink. This doesn't. So yo-yo dieting is often one of the things that leads to progression of the disease. We also see conditions like IBS and Crohn's along with lipedema, and also vitamin D and B12 deficiency, tiredness, fatigue, brain fog. These are all conditions that we see, and especially when it's not diagnosed and it's not managed. Development and progression, well, we don't fully know. There's a lot of ongoing research into the genetics to look at other markers that can classify the disease, because at the moment it's really down to history taking and clinical examination. But what we do know is that some of the drivers are hormonal, because the onset is invariably puberty, pregnancy, perimenopause or postmenopause. Although it's not fully understood, but we think that the contraceptive pill and HRT also may be triggers. Obesity is definitely a trigger, and it's very easy for these ladies to be trapped and become obese on the top of it. But lipedema is not obesity. So a lot of these ladies, they will repeatedly go to the GP because they say, why have I got these huge legs, it's disproportion, tiny waist, and I'm getting all this pain in my legs, I'm getting bruising, they have, a lot of broken veins and capillaries, maybe even varicose veins. If they're lucky, the GP may send them to see a vascular surgeon, but generally nothing is found. They get very demoralized because the doctors will say, eat less, move more, and of course, it's unresponsive to diet. So they really are gaslit with this. And then it leads to depression and sometimes a drug spiral, because they'll be put on antidepressants, they may be put on amitriptyline or pregabalin for the discomfort in their legs. They may even be put on diuretics, which don't work and again have their own issues. So differential diagnosis, how do we, because GPs will just say you're fat, and ladies, if they don't know any better, they just go away and feel generally miserable. So differential diagnosis, how do we diagnose it? So how do we know that they may be misdiagnosed as lymphedema? Now the problem is here, and where it gets complicated, is that these pathologies can exist with lipedema. So you can have lymphedema, and you also can have obesity on the top. But generally, we look at gender. So with lipedema, it is invariably exclusively females. There is often a family history, not always, but often there'll be a mother, grandma, aunt, sister, etc., that will have the disease. And some of my patients, I have 3 and 4 generations of ladies with the condition. The age of onset, generally it's at times of hormonal changes. So the usual onset is puberty. With lymphedema, if it's a primary, then yes, it will come on in childhood, but generally secondary lymphedema comes on later on in life. With obesity, you can get childhood obesity. Excuse the noise, we've got some work going on here. But it can come on usually later on in life. Areas affected, well, with lipedema, it is very restricted, and consequently you have this pear shape where lymphedema is not symmetrical like lipedema, and it can affect anywhere in the body. And obesity, again, generally tends to be all over. The effects of dieting and calorie restriction, well, in lipedema, it has no effect. In obesity, you will lose weight and your shape will change. And obviously with lymphedema, it can have a significant improvement on the condition. But again, we're looking at conditions, lipedema and lymphedema are not curable, but we can maintain them. So stemocine is where we pinch a bit of skin above the second toe. And generally in lipedema, the sign is negative and there's no pitting. In lymphedema, we have a positive stemmer sign and we often have pitting, which is where if we apply some pressure to the skin for a few seconds and we release it, there's a very definite dimple there. So that's another way. With obesity, we don't have any of that. Bruising in lipedema is very common and not really so in the other two conditions. Pain is a very common association with lipedema. Lymphedema can be uncomfortable, but you don't generally get pain with obesity. With the skin, with lipedema, is generally softer and plumpier. With lymphedema, it becomes quite thickened and you start to get more fibrotic changes. And in obesity, the skin is generally normal. And again, with elevation, with lymphedema, elevation can have a good effect. You do get ladies in lipedema that will get an orthostatic. If they've been standing all day, their legs will get swollen. But generally with obesity, you put your legs up, it doesn't make any difference. There is a huge psychological impact, and that really applies to all three conditions, but very definitely with lipedema and lymphedema, because it affects clothing choices, it affects footwear, what you can have, and mobility, and they're big issues. Clinical diagnosis, there's no tests that can prove or disprove at the moment a diagnosis of lipedema. There are MRIs, CTs, ultrasound, they can all be quite helpful, and certainly even DEXAs and vascular checks, and sometimes they're important to do to rule out any other vascular issues. But generally, our diagnosis relies on us taking a very clear and concise medical history, and also these tests that I mentioned earlier, stemmer and pitting, but also a physical examination of the tissue. And that's both visual and palpating. So family history, I've alluded to that a little bit earlier, that there is very often a genetic connection, but not always. There'll be the history, as we talked about, with fatigue, pain, hypermobility, often a history of joint problems, easy bruising. Then we come to looking at our physical examination. So we're looking visually at somebody, and even when they have a bit of concomitant obesity, you can actually still very much see this disparity in shape, smaller torso to lower body. We're looking at that. We're looking at it being symmetrical. We're looking at it being bilateral. We're looking for the cuff sign at the ankles. Quite often also the patients will have flat feet, they'll have fallen arches. They may have even had conditions like plantar fasciitis, etc. And sometimes because of the pain in the legs, they've often had other investigations for that. There'll sometimes be signs of chafing at the top of the thighs because of the inner thighs rubbing together because of these fat lobules. We'll see bruising, we'll see broken capillaries. And we're often able to palpate, sometimes especially in the arms and the upper arms. It's a bit like beanie bags, these hot packs where you can feel it's like grains of rice in the tissues. So we're palpating for those. Because a lot of ladies have lived with this for a long time, when we say, are your legs painful? Sometimes they'll say, no, because they've lived with it so long, that's they're used to it. That's how their legs feel, but they will still say, yeah, my legs do feel heavy. So we'll do a little pinch test. And usually then at that point, ladies will say, oh yeah, that's tender. So pain, and often also the tissues are cold to the touch. Even one lady did say to me, her husband always used to say how cold her bottom was. So they're signs that we use to diagnose it because of other existing comorbidities, and this is where it becomes very individual in our diagnostic process. We may then be writing to the GP to check for other issues that are going on and deficiencies, especially when it comes to things like vitamin D. We might also request other tests to check maybe for other conditions, although generally in blood work these ladies are really healthy, and you doctors expect them to have high blood sugar levels and things, and they don't. But we do ask for all these tests in some instances because of joint issues and pains and fatigue. We also may ask for some autoimmune blood tests to check for some of these other rare conditions. So we've diagnosed you, treatment and management, where do we go from here? As I've said, there is no cure. The condition can be maintained though, and there is hope, okay? It requires a multidisciplinary approach. So we do need medical support. We need to make sure you see your GP. We identify any thyroid problems, any other deficiencies, and we get those corrected. Also, there may involve a vascular assessment because there may be some refluxing veins, and so there may be some surgical intervention required there. Physiotherapy, osteopathy can be very good, and massage, manual lymphatic drainage, nutritional therapy. And I send a lot of my patients to Claudia because she's absolutely superb and understands the condition very well. Compression, not for everybody. There's no one size fits all. It's very individual in terms of treatment plans, but compression therapy can be very good for people. And there are a lot of garments now out there specifically for lipedema. Skincare is very important, especially in later stages or in lipolymphedema, because other conditions, hyperkeratosis, skin folds, fungal infections of feet can occur. Counselling, we have a fantastic lady that we refer to who does hypnotherapy and focused solutions for ladies, because there are lots of elements psychologically. It can affect their whole social lives, sexual life, etc. Surgery is available, not generally on the NHS. It is expensive, and we consider it, certainly in the early stages, it's a bit of a last resort. It's expensive. On average, some of our ladies are spending upwards of £21,000 because they might require 2 or 3 surgeries. So to do uppers and lowers, and that's quite complicated. And also you need specific types of vaser or water assisted liposuction, because otherwise you're going to damage initial lymphatics, and that's going to cause also other issues. And we may do another session in the future on lymphedema. Supplements, herbal medicine, as I said before, a lot of these ladies are put on medications by their GPs that aren't, may help with symptoms, but GPs are never going back in the causal chain of things to look at what's causing the problem, fixing it at that level, when then the symptoms will disappear. But there are some good, and I know that Claudia is going to talk about pycnogenol. There was a lovely study that came out at the end of last year on its effectiveness specifically in lipedema. So research, there's still an awfully long way to go. There's a lot going on in America, a lot going on in Brazil, and there are fantastic people around the world who, like me, are very passionate in helping ladies with the condition and trying to find genetic markers and other markers that we can find in blood so that we can very definitely diagnose this condition. It's a chronic condition. The definition of chronicity is something that, has gone on for more than 3 months, that causes problem, affects daily living activities, and that needs medical intervention. But unfortunately, to get a lot of treatments, NICE has to be able to diagnose it definitively. And at the moment, there aren't these tests. So hopefully that will be ongoing, and it's quite exciting because so far there have been factors found in blood markers that aren't always present in the general population that are in ladies with lipedema. So watch this space because that's very much an ongoing thing. So I've tried to give a quick brief overview so that we do have time for questions and answers. What I would suggest, sort of trying to summarize it, you're not alone. There are resources out there. The internet is always a good start, but please be very careful because there's a lot of good information, but a lot of ridiculous information. Join something like Lipedema UK. They're great advocates at £25 a year. They have wonderful resources, and it's a great group. They do, online sessions where you can connect with other ladies that have similar problems and understand what you're going through. And currently it's estimated that between 11 and 12% of the population actually have lipedema. So we need to educate GPs because for far too long, and currently, ladies are still being gaslit and being told they are just simply fat, and that is not the case. Okay. So we need to get these diagnostics out there to GPs, and my daughter-in-law, who's also in our clinic, and I, this year we are intending to do a program with more education for GPs. We work very closely at the clinic with a wonderful vascular consultant who over the last 20 odd years is really up to speed now with lipedema, and he understands this. There are lots of garments, compression garments out there, and compression therapy is not a science, it's an art. So if you've been lucky enough to have been signposted by a GP to a lymphedema unit, and you've been measured and put into compression, and you've tried to wear it and you've given up and it's gone in the cupboard, don't despair. At the clinic here, we very much have a multidisciplinary approach to this condition. So we use MLD, we use depostulation, we use physiotherapy, we use a lot of techniques to help break down fibrotic tissue. This year we've connected with a scientist who's developed some topical products that are used with wraps that look very promising in also helping with lipomas and nodules. So that's exciting, and we're recruiting people to join us and see how effective that is. Diet, we signpost people to Claudia because that is very important. You are what you eat. What you eat is eaten, and there's no one size fits all with diet. There has been some evidence that a ketogenic, Mediterranean, or a hybrid diet is very helpful in these conditions. But as I say, it's it's not a one size fits all, and that's where Claudia comes in. We do look at counselling because there are a lot of psychological issues for these ladies. They often eat next to nothing. They isolate themselves. They feel guilty. They feel it's their fault. And it's not. So we really try and support all of our patients in a very holistic way. And that's what we're here for. We're here for support and onward posting and signposting. And we see ourselves as very much part of a multidisciplinary team. And that's our approach to this condition. So I hope I
That's
haven't gone on too long.
no, Carol Ann, it's absolutely amazing. But a burning question here. Everyone wants to know where your clinic is. And
We are right. We are based in Bishop Stortford, which is in Hertfordshire. If you are not in the area, can't get to us, then Lipedema UK have really good resources. They did a compilation with the College of General Practitioners, so there's the learning module, so they can give you details that you can take to a GP. They have leaflets on a differential diagnosis. Most MLD UK has a website and a list of practitioners. So find somebody in your local area, make sure that they are levels 2 and 3 and they have experience and they can diagnose the condition. A lot of our ladies will maybe go to beauticians or aesthetics for treatment, especially now there's been a lot of sort of Brazilian lymphatic drainage. It's not manual lymphatic drainage. It's very good. I'm not knocking it at all, and it works when you've got a healthy lymphatic system. But most of these ladies will, when we diagnose them, will say, "I always wondered why a massage was always painful for me." So MLD is completely different. It's very gentle. But going to a good practitioner, they will be able to get you measured for appropriate compression and do MLD. As I say, I'm not too sure that a lot of people, I've got a lot of tools in my toolkit. I started out as an aromatherapist. I did herbal medicine, I did reflexology, I did manual lymphatic drainage with the lovely Hildegard Wittlinger. I also trained with Mel down at Singleton Hospital in Wales. I do Castley Smith, and I put a lot of it together and do the Carol Ann method. I also have lots of skills in post-surgical scar tissue techniques. My daughter-in-law is a physio. She does lymphatic drainage. She does acupuncture. She's a musculoskeletal specialist, and my eldest daughter is a skincare specialist. So we have a lot of expertise in the clinic, and we have lovely people that we collaborate with, like yourself.
perfect. And what's your clinic's name so people can
Hands to Health, and it's the number two. So
hand
HENDS, the number two, Health, HEALTH. So
perfect.
our website is there. You can give out my details. I'm very happy, and I do telephone consultations with people as well. So any questions that maybe we don't get through today, I'm happy to get back to people and discuss it.
So kind of you. There's a question here. So this is about lymphedema. So I have recent lymphedema in my armpit and upper back from a mastectomy 20 years ago. Um, Kept a lot of lymph nodes, but not all.
Mhm.
Is there massage that will help this from getting worse?
Yes, MLD. There are also other things that we do. We use taping, kinesio taping. We use a deposylation machine, which is very light. So it's a question of rerouting. So you have a compromise. Lymph is consistently being produced. When you take lymph nodes away, it's like having a 3-lane motorway and suddenly you're down to 2, but you still got the same volume of traffic. So it slows down down that journey. So then in lymphedema, that leads to the swelling, and that can lead to fibrosis, sometimes after mastectomies. This is why we do a lot of post-surgical work and scar tissue work to release some of the tissue to enable the flow. She needs to go and see get somebody from MLD UK in your area, go and have an assessment. With truncal edema now, there are Solideer do lots of lovely, there's a super silver wave bra that can afford compression. It can be very difficult because some ladies will also not go and have a reconstruction. Some will have, and there's not an exact number of lymph nodes in axilla. So even if you say, well, I've had 5 removed, well, it depends. If you had 10 there, that's 50%. If you had 50 there, it's less. But the compromise is there in the system. So MLD is where you go to, and then you may need compression to maintain that improvement. And even though it's been 20 years, we can still do a lot of work on that scar tissue as well, if that's a problem. So it's an assessment, and there is treatment, and it's maintenance. So, don't give up.
Amazing. That's so helpful. One lady saying, could rebounding help or hinder this condition? I think she's probably talking about the lipedema,
Lipedema,
just
lipedema.
gently
Yeah.
bouncing.
I think definitely for the lymphatics, because the lymphatics do have a slight intrinsic pump, but unlike the arterial system that's under pressure, it isn't. So movement is very important, and that calf muscle pump to get the lymphatics going. So yes, I think rebounding can be good. A lot of ladies and centres are even suggesting these vibration plates. But again, there are some contraindications to those. And anything that you're doing, you start slowly, and do it in conjunction with advice from somebody. But I think they have a place.
Brilliant. Oh, what about all the lymphatic drainage exercises that you see online,
Yeah, yeah.
Are there things that people can do themselves?
Absolutely, absolutely. And when you come to us, we teach you a simple lymphatic drainage routine. We tend to make that bespoke,
Mm.
because, like that previous lady, when you've had lymph nodes removed, you need to be taking that lymph somewhere else. But no, they can be good. Join the LSN. That's only something like £20 or something a year. There again, the lymphedema support network. And on there are links to simple lymphatic drainage. And there are videos, so you can follow along with the video.
It's amazing. Amazing. Thank you so much, Carol Ann. This has been so incredibly comprehensive. And I know it's just I don't want to sound negative, but it's just so frustrating when you hear that 11 to 12% of the population potentially have this, taking on
Yes,
average 20 years to diagnose.
I know, I know.
This
It's
medical misogyny gone bonkers, hasn't
Uh,
it?
absolutely, completely. I had a lady at the end of last year who is one of our ladies with lipedema, yo-yo dieted for years. She really struggled over the threshold, was wearing big baggy clothing. And now she comes in leggings and a top. She's walking better, psychologically, she's a lot happier. She had to go and see a new GP for an unrelated condition. And I always give my ladies cards and say, educate your GPs, always have this in your bag, don't be gaslit. And she said to the GP, I've got lipedema. Are you aware of the condition? And she said the GP just looked her up and down and went, you're just fat. And she was so with her permission, I wrote a letter to that GP, and it was an educational letter for that GP, so that hopefully now no other lady is going to walk into that surgery and be told by the GP that they are fat.
It's shocking, isn't it?
It is,
Okay.
and as I say, psychologically, there's often so many issues that people don't understand, and within the clinic, it's a safe environment to discuss these. You know, often intimacy is a big problem for these ladies. We advocate in terms of exercise. You were talking about rebounding. We like our ladies to do aqua aerobics because often if they do have concomitant obesity, you're supported in the water. You've got the external pressure of the water also having a massaging effect. The local ones are so full with all our ladies now. I think there's a waiting list, but there's often an aversion for ladies to go. I had one lady, she was an elderly lady in her 80s, spent an hour in the pool before she felt she could get out till people had gone. She was so ashamed of her legs. And we've got to get beyond that. So aqua aerobics, yoga, walking, all of these things. But you have to get fit. And a lot of these ladies have shut themselves away. They say to me, yes, I love swimming, but I won't go and let people see me. And we've got to get beyond that. We've got to
Mm.
give them the confidence.
Yes, yes. Absolutely. Oh my gosh. Right. Any final questions from anyone? It's an amazing opportunity to pose Carol Ann some really specific questions. You talked about surgery as, and
Yes. I mean, recently I'm aware that there was a recent with comedian on this morning about her diagnosis and going to Dr. Wolf. Now, Dennis Wolf, I've met him. We see a lot of his patients. If we are going to advise patients to go and consider liposuction for lipedema, we do send them to Dr. Wolf, and no disclosures. I don't get any payback from referring to him, but he does know the condition, and it's not something to take on lightly. You know, you have to wear compression 24/7 afterwards for a period of time. You need to come to us for regular lymphatic drainage following the procedure. But it can be life-changing for a lot of ladies, both physically, physiologically, and psychologically, because it often helps with the mobility. But it's not for everyone. And the other thing to bear in mind, it doesn't give you normal legs. You know, sometimes you'll need several surgeries, and sometimes you may then need to go on further and have a thigh lift or an arm lift because you've got this overhanging of skin. So with a lot of ladies with obesity, we haven't really discussed GLP-1s, but you know, they're being advocated for in this condition, as well as with obesity. There are pluses to that. There's not enough research yet, and it's ongoing. But I know you have a program for people to do this without going onto medication, and you know, they definitely need support if they're going to do that. But a lot of initial weight loss leaves you with this overhanging. And so sometimes then you need to go, and there's more surgery. Some ladies go through bariatric surgery. That doesn't always ameliorate a lot of the issues. So you need to go into it with your eyes open. What we're trying to do is get this message across, get the education, get ladies early enough that we can stop this in its tracks. look towards research throughout the world. I went to the first World Congress in Potsdam in 23 on this, but sadly caught COVID and spent 8 days in a German hospital with COVID. But the second Congress was held last year, and they've just published the outcome. The Lymphedema World Alliance on issues with lipedema to try and get some consensus, to get some general agreement, because this is also the problem with diagnosing. There's not enough specific criteria. And I've taken you through a lot of the criteria
Yes.
that we use. Pain in itself as a diagnostic factor, probably 70% of women do have pain, and it's a major thing. Even dogs jumping up on them, grandchildren running into them. It's painful. Husbands touching them, it's pain. But pain is very subjective. So pain is what you say it is. And if you have a high threshold to pain, then it's not going to be so much of a problem to you as those ladies who have a low threshold to pain. So this is when they will be put on drugs like amitriptyline or gabapentin or even painkillers. And then they need more and more of these. And then we start to get into comorbidities and constipation and polypharmacy. And so it rolls on. So if we get them early enough, we can avoid some of these pitfalls.
I mean, I find from a nutritional point of view as well with pain, if we can reduce inflammation, if we can support the body's response to
Yes.
stress, because we know that the more cortisol we have flying around our bodies, the more sensitive we feel to pain. So,
Yes, yes, but you're quite right. Inflammation is one of the underlying problems with this condition and with all
and
three conditions.
exactly, and that is actually why it's so exciting about the pycnogenol supplement. So,
Yes,
guys, it's in the chat. If any,
absolutely.
so that is marine pine bark.
Yes,
It's from a tree, and it is
yes.
incredibly supportive for any kind of venous, capillary, veins, arteries. I mean, I use it for clients with hemorrhoids. I use it for clients with blood
Mm,
pressure issues, the whole spectrum, and of
yeah,
course, lipedema as well. And reducing inflammation, I think, is absolutely something that we could, because we want to give you takeaways as well. What can you do for
yes,
yourselves? And reducing
absolutely.
inflammation is the really big one.
Yeah, and
Um,
now we've got this paper that came out last year. So now we've got the validation,
yes,
and I
because
think
we've seen it.
that's the important thing.
Yeah, but we've seen it in clinic, haven't we? With
Yes,
the pycnogenol,
yes,
I've
yes,
definitely seen it. I've
yeah.
seen as well the impact of GLP-1s on clients
Mm.
with lipedema, and I've seen what happens when people take GLP-1s and they've got lipedema, and then they come off the GLP-1s. They haven't done anything about addressing the underlying inflammation. The weight will just
It just
rebound,
rebounds.
rebound
Yes,
straight back
yeah,
on. And
yeah, yeah,
whereas then with the same similar clients with that kind of history, then they come to me, we work on reducing their inflammation,
yeah, yeah,
and it's
yeah,
made a huge difference. They've continued to lose weight after the medication, after the GLP.
yeah. And in a safer and a better way. I mean, a lot of the side effects were always known about, and this medication was primarily just for diabetes. But obviously, now we're learning more about the issues with people having to have gallbladders removed, the
But
problems with eyesight and
yeah,
blindness.
I know. I just think if people take the GLP-1s with the right nutrition, because like the
Exactly.
gallbladder issue is because people aren't eating enough, so the
Yeah.
gallbladder stagnates, and then there's a
Yes.
build-up of gallstones and inflammation and everything else. It's
Yes.
same with, like, for example, bowel obstruction is a side effect. But
Mm, mm.
if we can help make sure people are eating enough protein to
Yeah.
avoid losing
Fiber.
muscle mass, getting the fiber to avoid the bowel
Yeah. Yeah.
obstruction, supporting the gallbladder, that there are ways of
Absolutely.
doing it. But even what I've seen in my practice is even people with lipedema, they're not going to have dramatic weight loss on GLP-1s. It's going to
No.
be very slow. And
Yeah.
so don't have big expectations either,
Mm.
about how
Yeah, and
quickly.
diet. I always explain it to my ladies. I mean, it's not really a one size fits all, and that's why they need to come to professionals like you. I liken it to sort of cars. We have electric cars, hybrid cars, diesel cars, petrol cars, and racing cars, and they're all fueled differently. And if you put diesel into a petrol engine, well, you're in trouble.
Mm,
So, our bodies, we're all fueled differently. And that's without even coming into whether you're a carbohydrate or a protein type of person. And then that's taking aside your taste buds and your likes and your dislikes, or even religious restrictions with foods.
mm,
Celiacs, for example, who can't have gluten. So diet and nutritional advice is as you do, it's a one-to-one.
mm.
So, you're looking at that individual, and I hate the word diet because
Oh,
it conjures up, that idea of calorie restriction and being hungry and having to avoid things.
but Carol Ann,
And it's not.
yeah, it's got the word die in it. Who wants that?
I
Awful.
know, it's terrible. It's
Um,
terrible, terrible,
uh,
terrible.
so
So,
and there's a question here. Could Carol Ann write her surgery address, please? Or I've got the chat up if you want to just tell me, or your phone
yes,
number or
yes.
something, or your email, the best email to get in touch.
Yeah, well, the address simply is Willow 9 Willow Close,
So it's
Bishop's so
hands.
hands to health. It's one and the same, the address where we are. So 9 Willow Close,
Yeah,
Bishop's Stortford, and that's Charlie Mike 23 to Romeo Yankee.
there we go. Perfect. Thank you so much.
Hey.
Well, a huge, huge thanks for joining us today, Carol Ann. It's been
Oh,
such
it's been
a
fun, and I hope people have enjoyed it. I can talk for England, and I very often will go, off piste. So
no, no,
I've
it's so
tried to
great.
keep myself
But
on
it's
track.
so great that if, people are far away, if they could book in a Zoom call or something with, is that how you do it?
We can do that, but an element of this is that you do need a physical examination and feel of the tissues. So MLD UK will have a register of qualified therapists that people can look up and go to see. If financially seeing somebody in the private sector is difficult, then you can go to your GP and hopefully they can refer you to a local lymphedema unit. We did go through a period where they weren't seeing patients with either primary lymphedema or lipedema, but I think, a lot of that has changed. You won't necessarily get a hands-on treatment, but you can be measured and fitted with compression garments. But as I said before, compression is not a science, it's an art. And there's an awful lot to compression as well. So, we tend to, because a lot of these ladies will not fit off-the-shelf compression garments. So we regularly run measuring clinics where we get reps in from the compression companies and we get ladies made to measure garments. And now it's brilliant because a lot of these companies have specific garments for lipedema. We have trend colors in compression. We have patterns in compression. So, you don't, it's not about being Nora Batty.
Oh my gosh, Nora Batty, haven't thought of her for years.
That's aged me, hasn't it? Apologise for any thumping and banging, but as I say, we're having some
Oh no,
some
we can't
work
hear it.
going on, so good.
Zoom's very
Okay,
clever like that. Okay, fantastic. Well, Caroline, thank you so much for starting your week with us. It's been absolutely brilliant. And I know everyone's really grateful for all the insights. And thank you,
great.
thank
You're
you.
welcome. Thanks for asking me.
Thank you. Yes, yes. Someone saying thank you so much for this education. Amazing. Because when I did post about it, about you coming, there was actually quite a number of people who said, "Gosh, this is exactly what I need." Because,
Oh, good.
like you said, 20 years to get a diagnosis. No wonder. It's
I
lots
know.
of people saying thank you in the chat. So
Oh, I'm so pleased. That's great.
thank you
Well, I
so
hope
much.
everyone has a great week.
Absolutely. Thank you so much. I'm going to
Okay.
stop the recording.
Welcome.